we all are ready for today's session. So it's my great pleasure to invite our first session's chairperson. I would like to call Dr. Vijaya and Dr. Geeta Lakshmi, who is our chairpersons for the session 1. Welcome, ma'am.
I think she doesn't need introduction for speakers who have come from other states. So she is a HOD of ESI Medical College and Hospital, Chennai. She is a former director of IOG, which is the prestigious institute in Chennai. President FOGCE Chennai 2024, where I am an executive committee member. In her presidentship already, I think the Chennai is packed with knowledge and programs. She has special interest on high-risk pregnancy, infertility and laparoscopy. So I think she is the correct person to chair the session on recurrent pregnancy loss first session. Shortly, I think Dr. Geeta Lakshmi will be joining the session. We'll start with our first speaker. Yes.
Thank you, Aruna.
So I request Dr. Indhumathi Joy, the first speaker of first session today, to please come on dais, and I want the audience to give her a big round of applause. Welcome, ma'am.
Session, the opening batsman, and she's a senior consultant in Nova IVF Fertility, Annanagar and Vadapalni. Experience in the field of OBS GYN for the past 25 years and in reproductive medicine for more than 15 years. And she's a member of ASRM, ESHRE, FOGCE, TAPIZAR, IAGE, PCO Society, and invited the faculty to conduct fellowships in, can I have the CV please? Academic webinars and presentations in national conferences, authored several papers and journals pertaining to reproductive medicine and andrology, and her areas of interest are minimal stimulation protocols in IVF and gynae endoscopy. Over to you, Indhumathi.
Thank you for the kind introduction, ma'am. Good afternoon to one and all. At the outset, I would like to thank Dr. Aruna for considering me and giving me an opportunity to swim in this ocean of RPL, where totally everything is inconclusive, but I have tried my best to put the guidelines together. So this was the article from which I could take as much as evidence as possible, because this is the ESHRE guidelines of 2023, which is very close to the practices which we have been practicing for many years. So first, starting with the diagnosis of a recurrent pregnancy loss, it could be considered only after the loss of 2 or more pregnancies. So what is a pregnancy? It's from the time of conception until 24 weeks of gestation. And this includes non-visualized pregnancy losses and visualized pregnancy losses. So non-visualized pregnancy losses are biochemical losses. Both resolved and treated pregnancy of unknown location also are included in this. Ultrasound done after complete expulsion of an embryo also are considered. This excludes ectopic and molar pregnancy. And consecutive versus non-consecutive, even if it is going to be same etiology or the same prognosis, we have to consider this in the pregnancy wastage. And we have to avoid spontaneous abortions, chemical pregnancy and blighted ovum. So starting with how to go about treating a patient with RPL. So the guidelines say that we should have a dedicated RPL clinic. So that should have a separate staff, the treatment plan, and counseling team, where we have to draft out what the patient is undergoing and how to go about. So in the sense that everybody should be talking the same language, and tests, what are the tests we are going to do and the explanation for that, and shared decision making and individualized psychological support. So the guideline says first we have to start with the risk factors. So age is an important risk factor, we know that. So I'm just not going to read everything, but I'll just brush through as much as possible, because this particular guidelines, which is very useful for us to practice RPL, is it runs for about 138 pages. So I cannot put everything in 15 minutes. I'll just brush through it. So risk factors will be, the more age they are, the more is the risk. And stress, it has definitely a causative factor, and BMI, optimum BMI is recommended. So if you just want to see how the guidelines are being done, you just see the last column where the good practice points alone are published. So smoking, cessation of smoking is recommended, and in alcohol, limited alcohol is recommended. And then lifestyle and family history, medical history should be used to tailor the diagnostic investigations in RPL. Like for example, what they say is if he's going to be a chronic smoker or a chronic alcoholic, there is no point in starting him on antioxidants, because we need to stress the importance of lifestyle management. So lifestyle factors for both the partners, medical history in thrombophilia, PCOS and diabetes, family history, rule out hereditary thrombophilia, and whether there is a longer time for pregnancy. So screening for genetic factors, actually there is no role for screening for genetic factors. It is not routinely recommended, can be done only for explanatory purposes. Like you have to explain why it is not happening, then we can do the karyotyping of the fetus, karyotyping of both the partners. And genetic analysis of pregnancy tissue is not routinely recommended, can be done for the explanatory purpose, and they do it by a CGH method. And parental karyotype again after individual risk assessment. If there is a previous child with congenital anomalies, unbalanced chromosome abnormalities, then they do recommend. And translocation in the pregnancy tissue also, if there is anything associated, then we can do this. Thrombophilia screening, hereditary thrombophilia, it is not recommended again, except for research setting, additional risk factors or any family history is there. So totally to be very frank, whatever we have been doing so far, thinking that there could be an association and a treatment plan, everything is not recommended here. So we'll have to think more when we write the routine test for the patient. So even for a thrombophilia screening, they say there is a very weak association. So whenever we have 2 miscarriages, we write a huge list of protein C, protein S and antithrombin deficiency, but they say it is not recommended. So again, thrombophilia screening, in hereditary thrombophilia itself, when we have the evidence that there could be a history in the family, there also there is a weak association and an unclear contributing factor, so it is not recommended. And in an acquired thrombophilia, only if there is a lupus anticoagulant positive or anticardiolipin positive, both IgG and IgM, not only IgG but IgM also, then we can take this as a positive history. An anti-beta-2 glycoprotein possible but not statistically significant, so it is not a routine test. Now immunological screening test could be considered only for explanatory purpose. So what do we do? The anti-nuclear antibodies are not mandatory. So other immunological screening like anti-nuclear antibodies and HLA typing, they have only this HLA typing alone has a strong association only in family history, but otherwise it is not recommended routinely. So what are the tests that are not recommended, which are not supposed to be done? HLA compatibility, all HLA types actually, and cytokines and polymorphism in cytokine gene, anti-HV immunity, natural killer cells. So we can't measure all this anymore. Anti-sperm antibodies, anti-HLA antibodies, celiac disease antibody, all these are prohibited from routine checking. And thyroid screening can be done. And thyroid screening, we have to do TSH and TPO antibodies. It is recommended in women with RPL bodies, but this we routinely do. Even if they come for fertility issues, we do the thyroid screening. Abnormal TSH levels should be followed up by T4 testing. So again, we have a list of tests which are not recommended. In a PCOS, we can do this because thyroid is a contributing factor for PCOS, so we can do that. And insulin resistance, sometimes with the PCO, it is associated, so we can do. Other than that, fasting insulin, glucose, androgen levels, free androgen index, elevated serum LH, prolactin, ovarian reserve test. Ovarian reserve test itself, they are telling it is very unclear, it is not recommended. And luteal phase insufficiency, then homocysteine levels and vitamin D levels. Vitamin D level has a possible effect on the PCO, so it can be done. So, and then screening for anatomical disorders, a normal 2D ultrasound, if there is any abnormality, followed by a 3D ultrasound is what is recommended. And for anatomy, for cervical weakness, diagnosis based on a history of second trimester miscarriage preceded by PPRO or painless cervical dilatation, and there is no objective test in a non-pregnant state. For male factor, we have to assess the lifestyle factors in male. The most important ones are the easily neglected ones. One is the age, smoking, alcohol, exercise and BMI. If we are not addressing these 5 issues, then there is no role for any antioxidants in that male. So, assessing the prognosis for RPL, it is basically based on the woman's age, her complete pregnancy history, including the number of previous pregnancy losses, live birth and their sequence. So, the recommendation is all couples with the results of an abnormal fetal or parental karyotype should receive a genetic counseling. Inform about the possible treatment options of PGT, natural conception with prenatal testing, gamete donation and adoption. So why are we discussing this in a genetic background is, there is very low quality of evidence that even if you are going to do a genetic screening, you are going to get results in the next pregnancy. PGT-SR could reduce the miscarriage rate but will not improve the live pregnancy rate or time to pregnancy. We need good quality evidence RCT with modern technology and methodology. So now going on to the treatment. Treatment of RPL with thrombophilia. So I'm dealing with guidelines and treatment of RPL. So I have missed a whole lot of a section in between because it is dealt with by the rest of the speakers. So in the treatment of RPL with thrombophilia, what the guideline says, if it's a hereditary thrombophilia, antithrombotic only we should give. So that too only in a research setting where you will be able to manage the complications, and we should give them venous thromboembolism prophylaxis. So what is the benefit? Systemic review. The systemic review says there is no benefit of low molecular weight heparin for prevention of pregnancy loss in hereditary thrombophilia. And in acquired thrombophilia, as I already told, when we have evidence that this is positive for an APS with more than 3 pregnancy losses, then we start a low dose aspirin, 75 to 100 milligram per day before conception, and prophylactic dose after positive pregnancy test. Combination of heparin and icosapent improves live birth rate in women with APS and RPL to 80%. So treatment of RPL with metabolic and endocrine disorders in an overt hypothyroidism before conception and during early gestation, we have to treat with levothyroxine. And this is, as far as I know, this was the only thing that was beneficial in the whole of the article. They were stressing more on the lifestyle management and thyroid treatment and management of obesity. And subclinical hypothyroidism treatment may reduce the risk of miscarriage. Balance the potential benefits of treatment against the risk. Once pregnant, recheck the TSH by 7 to 9 weeks. Thyroid autoimmunity, euthyroid means we need not treat. Once pregnant, recheck thyroid by 7 to 9 weeks. Luteal phase deficiency, progesterone insufficient evidence to improve the live birth. HCG insufficient evidence to improve the live birth. Ovulation induction in PCOS, evidence is too limited. Glucose metabolism defects, metformin, insufficient evidence to prevent the pregnancy loss. Vitamin D, preconception care, consider supplemental vitamin D only in cases of PCOS. Treatment of RPL in uterine anomalies. In congenital disorder, if it is a septate uterus also, septal resection does not show any benefit based on the international multicentric trial. This was done in 2021. Bicorporeal uterus with a normal cervix also, metroplasty is not recommended. Hemiuterus, uterine reconstruction is not recommended. And bicorporeal uterus with double cervix, insufficient evidence to say that any metroplasty or cervical surgery is going to help the pregnancy. And acquired disorder, submucosal fibroid, hysteroscopic removal is recommended, but there is insufficient evidence. Intramural fibroid, myomectomy is not recommended as a routine. Fibroid distorting the uterine cavity, it is recommended, but there is insufficient evidence. And intrauterine adhesions, hysteroscopic removal, but there is insufficient evidence. So what they say is they have been constantly practicing these practices once we see the abnormality, but we don't have enough RCTs for us to lay down and say that this can be done as a solution to treat this problem. So cervical insufficiency, history of second trimester losses or cervical weakness, serial cervical sonographic surveillance is sufficient and there is no role for prophylactic cerclage. And singleton pregnancy, a cerclage can be considered, and history of second trimester recurrent loss attributable to cervical weakness, no evidence that this treatment increases the perinatal survival. So with a male factor, So this is something, see, this RPL guidelines have been they have started from 2011, 2017, and then 2019, 21 and 23. So all the guidelines have been changing from, for every guidelines they print in ASHRAE and ASRM, they keep changing. But something that was recently included in 2023 is the male factor. Male factor was not addressed to a larger extent in the previous guidelines. So what they say now is in the lifestyle changes, cessation of smoking, normal body weight, limited alcohol consumption and normal exercise pattern. And many of them with the poor parameters, they suggest FOGCE, but FOGCE has no evidence to support in RPL. And antioxidants, again, they do not increase the live birth rate. And treatment of unexplained RPL, what they say is in vaginal progesterone, when they have more than one pregnancy lots itself, when they use vaginal progesterone, 400 milligram from 6 weeks to 12 weeks, there is an increase in the clinical pregnancy rate. So this is something which we can rely on. So this is based on a meta-analysis. Benefit of progesterone on miscarriage rate and live birth rate. Oral dydrogesterone after fetal heart reaction scene may be effective also. So we can use dydrogesterone and micronized vaginal progesterone. So high dose of IV immunoglobulins also, it might improve the outcome, but we don't have high quality RCTs. And so what is not recommended is more important. One is lymphocytic immunotherapy should not be used. No significant effect, may have serious adverse effects. Corticosteroids and then intralipid, GCSF, heparin and low dose aspirin, and IVF plus PGT. PGT also is not routinely recommended unless they have a abnormal child in the family where they recommend PGT SR. Endometrial scratching has no role, and low dose folic acid for prevention of neural tube defects only, but not for recurrent pregnancy loss. So psychological impact of RPL is very, very important. They say pregnancy loss is a significant negative life event, and the repetitive nature of RPL may intensify the grief experience. Studies have mostly focused on women. Yeah, I'm finishing. And there is a need for studies on the emotional impact of RPL on men. Clinicians and clinics should take the psychosocial needs of couples faced with RPL into account when offering and organizing care for these couples. TLC it has only limited evidence. That itself will improve the pregnancy outcome. If not, it is hard to argue against this approach. So what is routinely recommended is the thyroid and a 3D ultrasound, and if they are anticardiolipin positive, then we have to give them heparin. Otherwise, there is no role for that. And to explain why things are not working out, we can have ANA, sperm DNA fragmentation, and a CGH for the pregnancy tissue. And in selective cases only, we can do the parental karyotype, HLA class 2. And the study was done on Scandinavian women, so we don't have evidence for our Asian population. And others not recommended is other immunological tests and metabolic and endocrine markers. So genetic defects, we have to do genetic counseling, pros and cons of PGT, antiphospholipid syndrome, aspirin before conception and heparin after positive pregnancy test, uterine anomaly, insufficient evidence on surgical is enough, thyroid problem, we have to supplement with thyroxine, and high sperm DNA fragmentation, again lifestyle changes, FOGCE and antioxidants, no role. Specifically, they are telling FOGCE because usually they advise FOGCE for increased DNA fragmentation. And ANA positive, no specific treatment, unexplained vaginal progesterone is enough. So, thank you so much for the opportunity. So, medicine is the science of uncertainty, we all know, and it's an art of probability. So, we have to make the calculation and we have to do the best, whatever is possible in our hands or the clinic for the couple. Thank you so much for the opportunity.
Thank you, Indhumathi. As usual, this is always a mystery, and whether to do it or not to do it. And as per your thing, the definition of spontaneous abortion, biochemical loss, all those things should be gone. The other one is this ectopic and molar. It should not be considered as a pregnancy loss. That is also one good point. And apart from that, almost all are no. isn't it? Whatever the test we are doing and the steroids and the heparin, all those things. And it's a very good take-home message. Thank you so much for a good talk.